shortly summarize the workshops, and then Wolfram Brenner, who will take the lead of the council officially in summer, but in reality already after this meeting, will have the concluding remarks. And then we will meet downstairs for a nice lunch. Allow me to ask Mikhail Mazigi to summarize workshop 2 discussions.
Thank you very much. Alison Hallyday had to leave. She had to catch her plane, so unfortunately she will not comment with me, but I will comment for her. So our workshop was on catheter-based thrombectomy and carotid revascularization. Alison Hallyday showed us focuses on the technique and shows us a video. It was the opportunity to comment some points regarding anesthesia, underlining the fact that this type of intervention was mainly performed under a local anesthesia, although it could be also performed with general anesthesia, and in this situation shunting was performed. We also discussed with one group the fact that antiplatelet therapy should not be withheld for surgery. In fact, surgery could be performed with 1 or 2 antiplatelet therapy, so it's not an issue. Timing for surgery, guidelines recommend carotid surgery within 2 weeks after the stroke, unless there is a contraindication. For example, with a very large stroke, then the surgery is usually postponed for 1 month. Another point was also discussed was carotid surgery before cardiac surgery. Usually, carotid revascularization is not considered only for very specific cases where there is hemodynamic intracranial hemodynamic compromise. In this type of situation, then a revascularization of the carotid may be considered prior to cardiac surgery. Still, the workup to look for this type of situation is important for the anesthesiologist for the blood pressure management. On the other part of the workshop, we discussed a clinical case regarding thrombectomy. We've seen that carotid, or at least cervical artery dissection, is a very frequent cause in the younger patients suffering an acute ischemic stroke. It is not a contraindication for IV TPA. And we also discussed the management of patients who have carotid occlusion related to dissection, and the endovascular management considering stenting or other options like angioplasty, with the issue of intracranial bleeding in patients who have TPA on board and that theoretically need additional antiplatelet therapy when a stent is implanted. That's it, I think. Thank you.
Thank you, Mikhail. I was doing the 3rd workshop with Sven Wassmann, who unfortunately had to leave to the airport. So I give a summary of workshop number 3 for both of us. And we presented 6 cases. He showed 3 cases and I showed 3 cases. In cases of Sven Wassmann, that was a patient with paroxysmal atrial fibrillation and mild carotid plaques. And this patient had different, during the time, different level of cardiovascular score. And at the end, the 3rd option was that this patient, after a couple of years, suffered acute non-STEMI. So basically, we discussed the treatment of patients with combination of atrial fibrillation and carotid plaques, and combination of atrial fibrillation and acute coronary syndrome. And we discussed the duration and whether to use triple therapy or dual therapy, and we showed the guidelines. I showed 3 cases. One was, all 3 were thrombectomy cases. So I was focused on the acute phase of stroke. how to use antithrombotic medication in the acute phase. The first case was a young lady with acute stroke, treated very early after 1.5 hours with successful thrombectomy, and no obvious cause for stroke despite examination. And so this was ESUS in a young lady, and we discussed whether to use aspirin or oral anticoagulants. Majority of people in the room voted for aspirin, but some preferred anticoagulants. The question was also how long to treat such patient without any other risk for stroke, whether to start aspirin for lifelong or whether to use it for a couple of months or for a year. And most people prefer to start aspirin lifelong. Case number 5 was elderly female with atrial fibrillation, and thrombectomy performed technically successfully, but 5 hours after onset with severe residual ischemia, large residual ischemia. And there was a lot of discussion what treatment at what time should be initiated. So whether we should start in this lady oral anticoagulation, let's say 1 week after stroke onset, or whether we should bridge this 1 week by giving aspirin, or whether we should use low molecular weight heparin or other way of protection against deep venous thrombosis, and how to combine these treatments to avoid the risk of hemorrhagic transformation of the stroke. And there was quite a lot of discussion about low molecular weight heparin because it is not investigated whether low molecular weight heparin indication for venous thrombosis prevention in stroke should be used in the same way after thrombectomy, or if the recommendations should differ for patients with successful thrombectomy. And case number 6 was elderly male with successful thrombectomy and carotid stenting in the acute phase. And here we discussed the dual antiplatelet therapy, whether to start it in the acute phase immediately or whether to start after some delay, let's say after control CT shows that there is definitely no bleeding. And another discussion was also about stent timing, whether to implant stent in the acute phase or whether to implant stent after a few days, so 2 days, in other words, acute intervention when there is carotid occlusion or critical carotid stenosis plus another clot is in the brain, so-called tandem lesions. So whether to, in the acute phase, to only dilate carotid lesion and postpone stenting, or whether to implant stent in the acute phase. And these are questions which have no answer yet, so I hope that when we shall meet next year, we will definitely do this meeting next year. We don't have decided yet about the venue and date, but this meeting will happen every year from now. So these questions will be subject to discussions and debates and workshops also next year. And I would like to invite also Nathan for presenting the summary of his workshop. Nathan did workshop with Marta Rubiera, but Marta had also to leave for the airport, so Nathan.
Okay. Unfortunately, I'm not Marta. And the topic was IV thrombolysis, and Marta was kind enough to prepare 2 cases, typical cases, and of one was of a lady, relatively young, who is presented to the EMS with acute hemiplegia, aphasia, and somnolence. And the idea is that before we start, the EMS guy should start to ask we should ask ourselves 3 questions. First of all is when the symptoms started. It was 2.5 hours, there was witness to this. And the next question was what? And we discussed the different scales for pre-hospital assessment. In Barcelona, they use RACE scale, which is very common. In the United States, they have all kinds, Los Angeles, Cincinnati scales. The idea is to identify patients that are at a high or more likely to have LVO, left large vessel occlusion, and therefore the pathways within the hospital could be different. So this lady had a race of 8. Race above 4 means that this is a high race. A high race means more likely to have LVO. And therefore, the next question that we discussed is, now that you think the patient 2.5 hours after onset and the race is high and probably she is eligible for intervention, the idea is to ask, why not? This is the third question. We have to understand all the contraindications, and we discuss also the new guidelines regarding the contraindications, not the old ones. For instance, whether or not we should wait for platelets count. The answer is no. And definitely it was shown that we just waste of time, and patients with no history of thrombophilia or coagulability problems will not have any problem with that. The second point was that we have to know the glucose level. We discussed, at least in Israel, the EMS guys, this is one of the indicators or quality indicators. One is the pre-notification and the other one is the glucose level, in order to exclude hypoglycemia as the cause of. If anyone here, I ask in the audience, if anyone here can tell me why the hypoglycemia causes hemiplegia, because there's not only one part of the brain is hypoglycemic. I'll be more than happy, write to me the answer, because I don't know the answer. And so the glucose was 122, so this lady was eligible for intervention, definitely. So the question is, now we discussed the different pathways in different setup. The patient arrives to the emergency room, there is a stroke code. In Barcelona, the physician is activating the stroke code. In my place, the nurse, triage nurse, because at least half of the patients do not come with the ambulance. So there is no pre-notification. And then either the patient goes directly to the CT scan before he goes to the ER and do the triage. And if the patient is potentially eligible candidate for thrombectomy, at least in Barcelona, they may go directly to the angio suite. Not every setup can do it, and then we discuss whether if you think that there is, and you do CTA or you do angio, immediately you see M1 occlusion, that lady had M1 occlusion, whether you continue the IV TPA while doing the thrombectomy. My interventionists say, no way, stop the IV TPA. In Catalonia, I don't know if you do it the same, but they continue to do the IV TPA. And at least my interventionist, he says that either it's cause or high risk of bleeding in one hand, and the other hand it could fragment the plaque, the clot, and there is some of a distal occlusion later on downstream. Therefore, he doesn't want IV TPA on board once he starts the thrombectomy. And she did thrombectomy successfully. Now the question is whether, at least in Catalonia, they continue the IV TPA because they look for TK3. Successful thrombectomy is TK3. Most of the thrombectomy trials were for 2B, TK2B, not 3. But this lady had a TK3, and the NIHSS after 24 hours was 2 very successful thrombectomy. So this was basically the discussion. We discussed all these issues with thrombolysis. I was very glad that many cardiologists were in the group, and I showed them the CT scan. This is a brain, and they were very happy. Thank you.
Thank you very much, Nathan. And now is the time for Wolfram Denner to give a few concluding remarks.
Thank you very much. Yeah, it's on me now to give you the very last words for these 2 days and give you a short sum up of our feedback and our experience from this first meeting in this field. I would like to start to actually thank you for coming and putting in all the discussion questions and giving us this feedback on all the talks and the debates. Very important for us also to get your feedback on the format of this whole session and this meeting. You will receive from us an email asking again for some things you particularly prefer or what you think would be good to continue in the next runs of this session. I also would like to thank the faculty for putting in the effort to give all these presentations and prepare the cases and the debates and being prepared to face your sometimes tough questions. A special thank goes to Peter, of course, and his team for organizing the meeting here in Prague and to putting together the faculty and the topics that are, I think, timely and really up to date to bring us on a higher level with regard to background information on stroke. And a thank goes to the team from Cora, Laura from the ESC, organizing all the infrastructure for this meeting. And of course, I don't want to forget to thank the industry support, which is very valuable for us to actually make all this happen. So it was a great joint effort from all sides to contribute to this, I think, quite successful first meeting. It's a challenge for us, and we learned this as well, to bring together not only two specialties, but from the discussions I had yesterday and today, I learned that there are many more different specialties are among us. And some of the challenges, or one of the challenges I realized is that it's really, even in the presentations and in the dialogue, important to keep up with the level of non-specialists in their own field. It starts with the language and the presentations, where abbreviations sometimes really make you getting lost because it's what you know on your everyday work, but the colleague from the other specialty actually needs to get to brought up to that level of information. So this is something we will carry on in our experience for the next meetings. We will definitely we feel encouraged to continue with this meeting, to cross the bridge between strokeologists and cardiologists, and we will have a further meeting for this next year, where we encourage you again to come if you want, and to also encourage colleagues to do this. One aspect we did, I think, not mention so far, but it's important to tell you right now. This meeting is CME accredited, so with the email you will also receive CME points for this meeting. And with this, I think maybe just the one last sentence, we achieved just above 100 participants, which was absolutely the target. So also from this point, we were quite successful with this first time meeting, quite a pilot for us, encouraging for the next years. And with this, just have a safe travel home, and all the best for you for the next year.